now it's optimization, because you can throw all of these flow sheets and all of these screens and all of this information. Okay, you got all this data. How do we make it make sense? It's presentation, but it's also digesting large clinical summaries that I really don't need to read all of this, but those things that are outside the norm, pull that out. Use AI or machine learning to pull those things out so I could quickly look at a snapshot of this patient before I move on to the next one. It helps me spot red flags very quickly. So got to use the tools to make it happen. And now we're in a new era, and I know how to do it, but I've got to let the technology be my guardrails at the same time. So how can we make it better for our nurses, which translates very easily to better outcomes for patients and family members?
Welcome to the Digital Healthcare Experience, brought to you by Taylor Healthcare. Subscribe now and stay on the forefront of the digital healthcare revolution.
Hello and welcome to the Digital Healthcare Experience podcast presented by Taylor Healthcare. I'm your host, Chris Civit-Therese, and today I'm joined by Mark Heyward Johnson with Prisma Health, where he's the chairperson for the Practice, Excellence and Informatics Council, and also serves as president of the American Nursing Informatics Association. Mark graduated from nursing school back in 1998 after serving in the U.S. Army. Thank you for your service, Mark. And Mark has been ANCC certified in informatics nursing since 2005. He's held roles in both provider and vendor settings, focusing on healthcare system selection, implementation, support, and development, as well as software business development. Welcome, Mark. It's great to have you on the show.
Great to be here, Chris. Thank you so much.
So, Mark, you wear multiple hats, from a full-time bedside nurse, an informatics leader, president of the American Nursing Informatics Association. Can you start by sharing how those perspectives come together to shape the way that you think about technology at the bedside?
Sure thing, Chris. Yeah, a lot of that all feeds together. After I got out of the Army, I had the fortune, and I want to tie it together, is where it started, really, is where I had a mentor. He was a colonel who was married to my wife's senior officer as well, because my wife was in the Army active duty. And he had the great foresight to say, hey, I know you're interested in healthcare, and I know how you do with information systems. And this was in the early 90s. We were, Windows 3.1. We were networking printers and really excited about that kind of stuff, using those big Bernoulli drives and WordPerfect and Harvard Graphics. And I had a really good opportunity to be mentored and someone say, look, you really need to look in this direction. So my mother was a nurse for 40 years. My sister's a nurse. I have a sister who's a nurse practitioner. So that's kind of run in my family. And I've always felt that was where I would go. And so when I got out of the Army and started my nursing career, I always had in my mind health information systems. This is something, how am I going to tie this together? So I was always looking for those opportunities. And when we moved from Washington State back to South Carolina, I went down the path of following a master's in healthcare administration with a focus on information systems, really just to open some doors. That got my foot into information systems, where I served for a while. So I had 6 years at the bedside. Then I started working in information systems, and still worked on the weekends. My wife was in graduate school, so I was doing extra work just to kind of get our family through that period. And then I spent 14 years working for a healthcare software vendor in the Meditech space. So I had the opportunity to build one of the first patient portals in the Meditech environment. We had that in close to 80 hospitals, I think, at one point, and all of that ramp up from meaningful use, all of that implementation, all of that work that went on. So right when COVID hit, that company that I worked for was sold, and we went from a mom and pop to more of a larger corporate publicly traded entity. And I started chasing spreadsheets a little more than I was dealing with patient care, and less opportunity to work with clinicians. So I had already gone back and gotten my BSN, and so I knew I was going to go back to the bedside. So I got a master's and then went back and got another bachelor's degree in nursing. Is how that kind of worked out.
That's great.
And so right when COVID hit, there was an opportunity for me to go back to the bedside. And so people thought I was crazy, but tell you the truth, in that environment, and I worked on a COVID unit, to get back on that bicycle after 13 years, it was a trial by fire. But I promise you, Chris, at the same time, everything was a trial by fire at that time. But
Sure.
I found the patients so appreciative of the care we were giving because people were struggling to breathe. There was just so much going on at that time, and it was kind of like a war zone to get back into that at the bedside. So now that we've kind of, COVID's still here. I was treating a COVID patient this week at the bedside, so we're still dealing with that, but we're not in that frenzied mode of just flying by the seat of our pants.
Right.
So that's given me an opportunity over those years back at the bedside to start looking more at the bigger picture, because I feel like I bring software implementation, support, sales and marketing, business development into a clinician role at the bedside. It is unique, but at the same time, Prisma Health has afforded me an opportunity to step up and utilize some of that experience to make things better for our 19 hospitals, and to work with our informatics team, to work with our IT analyst. So how can we make it better for our nurses, which translates very easily to better outcomes for patients and family members. So it's all one big circle for me. It's always been the lanes that I've marched in, and it's been easy for me to have those conversations, because that's where an informatics nurse really fits in. So we're translators, we're conduits. We bridge the clinicians with our IT folks and our analysts, and we're the ones that are in there doing the translations and saying, yes, I understand what that workflow is, and this is how we should build that or implement it, or if there is an issue, being able to speak those languages across all of those different departments that you're working with. So I do lean on it every day. I'm the guy that fixes every television in the hospital. It's hilarious, but I'm always called to go fix this television. And it's not just a technical thing. That's just one example. But in some folks' mind, that's who I am. But at the same time, I'm comfortable with technology. I think that's what that translates to. I'm comfortable with technology, whether it's patient-generated health data, whether it's patient portals. I'm always the guy that come to, can you help this patient who's discharging get on the patient portal? And it's just a level of comfort. Now, I'm one of those guys, I'll fly by the seat of my pants while I try to figure out a software program or an application. And, we've all had to call help support once or twice before, and then deal with that. But I think that helps my fellow nurses. So, because I always take that opportunity and say, here, this is how we're going to access this data. The next time you see this, teaching by example, teaching those nurses who grew up, that's what they've been, they've been online. I've been a nurse for 28 years, and I work with nurses that are 23 and 24 years old.
Right. Yep.
It's all native to them, that technology. So then you just expose them to these clinical tools and say, look, just like you do this is what you can do for your patient with this technology. So it's a matter of comfort and experience, and just an eagerness to stay involved with the latest technology and things that, that's my goal in life as a career, is making things easier for our patients and our family members, which then translates to better outcomes. And then at the same time, you're elevating the experience for our clinicians.
Obviously such an important mission. And obviously, that background that you shared with us is just tremendous. All those different points of views, just incredible, Mark. I want to go back to something you talked about. You talked about kind of the lead up and the build up to meaningful use. And obviously, we have electronic health records largely as a result of that have been obviously proliferated, ubiquitous kind of across all of healthcare. And I think it's hard to talk about, bedside technology without first kind of taking stock of where we are at the bedside in terms of EHR utilization, and some of the good, but also some of the bad, some of the pain points that we might be experiencing right now with the current technology stack that we're utilizing at the bedside. So can you talk a little bit about that for us?
Yeah, for so many years, it was fire hose implementation. And it's like, when I started my nursing career, I did everything on paper. And I'll be honest with you, sometimes I have to catch myself in my workflow because I think about, I just do something with muscle memory. I'm like, I got to stop. I've got to incorporate the technology here. I know what I'm doing. I know how to do it, but I've got to let the technology be my guardrails at the same time. Whether
Right.
that's medication administration or discharging a patient or whatever the case may be. So we went through all of that rapid implementation during meaningful use, and now we're in a new era. It's the exception to the rule that you if you don't have a AMR, whatever
Right.
the vendor might be, and we're down to like the top 3 at this point. So now it's optimization, because you can throw all of these flow sheets and all of these screens and all of this information, and the nurses always are the Harry Trumans. The buck stops with us, right? I mean, we're the ones
Right.
who own everything, whether it's a good idea or not, and we went through all of that implementation of, you have to deal with, oh, we did it on paper, or this is the way we did it in our old system. And that's where my counsel comes in. We look at things and say, do we really need to do it that way? Can we streamline this? Can we make this easier to understand so that it actually gets documented? And are we putting it in the right place? How hard is it to get to that flow sheet? Is it 3 layers buried, or can I access it on a mobile device? What is it? If I want my nurse to capture that information repeatedly, often it's 12 times a day in a 12-hour shift.
Wow.
Back in the old days, we had paper clipboards on the door. And if I came by to check on you, I would just initial everything was good. It's a different process where I have to think about, oh, I need to go find my WOW or my desktop to say I just walked by this patient's room. She's fine, not in pain. All my safety precautions are implemented. So now I've got to make it easy for me to document all of these things that I'm asking my nurses at the bedside to document. How do we do that? And that's something that we look at constantly, because the first instinct is just put it on another flow sheet, add another row.
Right. And you've described that as I think I've heard you say, a tsunami of flow sheets and data points. And, that is obviously it's been the knee-jerk reaction to, if we need this piece of data, put it on the flow sheet,
Right.
Just kind of create another line on an electronic form or electronic screen somewhere. So that's, I guess that kind of goes along with, as you say, a typical kind of 12-hour shift, why we're spending so much time documenting in a typical shift as a nurse.
Yeah, and the American Nursing Informatics Association, we've got some statements, papers and white papers about that, just that cognitive dissonance. You break down because I've got so much that I have to deal with. We call it the documentation burden, that
Right.
I get so overwhelmed about checking boxes and going down rows that I sometimes miss what's going on big picture or micro picture with my patient or family member. So how do we start incorporating those things into passive documentation, where use a proximity badge? It knows I was in the room. Document that. If I take a patient to the bathroom, is there a way for me to, ambient listening or whatever, monitoring with cameras, and smart toilets, they're out there.
Right.
How do we document those things so that nurses are there, they're taking care of those patients 12 hours a day? You may be in that room 15, 20 times during that 12-hour period. A lot goes on, and making it easy for our nurses to document all of the things, all of those touch points, is really what we chase now. It's that optimization,
Right.
so that we can capture the important stuff and at the same time let our nurses be nurses. We're the ones that patients trust because we spend so much time with them. We're the ones that are there.
That nurse-patient relationship, right, is, at the core of healthcare. Certainly, it takes a village to care for a patient, and there are so many dedicated professionals. But at the end of the day, I'm sure that those of us that have had experience with our local health systems and hospitals and so on, everybody knows the importance of that nurse-patient relationship. And I'm curious. So this documentation burden, certainly it affects the clinician. It affects the bedside nurses and what we're asking them to do and so on. How do you see it affecting patient care? And if we can improve those processes, what do you think happens to patient care and to that nurse-patient relationship? How do you see that evolving if we can make strides there?
Yeah, and a lot of it comes down to staffing being creative with staffing, creating an admission discharge nurse so that one person can focus on that intake of, okay, you're a new patient. There are certain things that we have to ask from a case management standpoint or preparing for discharge as soon as they're admitted. So it does, like you said, take a village, and definitely shout out to my respiratory therapists and my techs, phlebotomists, all the
Absolutely.
folks that are there at the bedside all the time. But I hear it less, Chris, these days than when I used to maybe 10 or 15 years ago, where I hear, well, you already asked me that. I don't hear that as much. And I think that speaks to how well we are using the same flow sheet field for multiple purposes. Where in
Right.
the past we may not have done that. And I've got to ask you again, and then again, back to that staffing, have pharmacists come along and let them do the home med inventory instead of like putting that on the nurse. So
Right.
we start to subdivide these tasks and these focus points so that the patient, the family members start to realize it's not just the nurse. The nurse is the person I'm going to see the most, but I've already seen the pharmacist. I've already seen a respiratory therapist. Phlebotomist was there as soon as I got to the room drawing blood on me.
Right.
But the nurse is still they're the captain of the ship for that team. They're the ones that they're going to go to first and say, hey, I need a respiratory treatment, or I don't like the way that lab draw was at 4:30 in the morning. Can you wait till 6:30? All of those little touch points, the nurse is still the face of that, and we have to take ownership of it. And to go back to that point, I think that's where we start when we have all of these, the ancillary folks coming alongside the nurse. I think that's where it helps the nurse say, okay, this is not, it is overwhelming, and the things I have to focus on repeatedly and finding those ways where I can do those things repeatedly. But I'm not responsible for all of this. I care
Right.
coordinate more than I sometimes do the actual care. I'm coordinating things. I'm calling people on the radio to go do certain things. So I think that, along with making it, using technology. So creative staffing, multidisciplinary approaches, and then using technology so that, how do I document those things that I do repeatedly? Like I said, that clipboard at the door. How do I make it
Right.
easy for me to go in and just answer 5 quick questions every hour on the 4 or 5 patients or the 2 or 3 patients, whatever the ratio is? Because if you have 5 patients over a 12-hour period, you may discharge 3 or 4 of them on a typical med surg unit. Then you might
Right.
get 3 other patients. You've dealt with 8 patients that day or 9 patients that day.
Absolutely.
That's a lot of information for anybody to process, especially in a critical situation. So we've got to have all of these tools and all of these multidisciplinary team members alongside the nurse. Otherwise, they just get overwhelmed.
Completely agree. And I mean, those 8 or 9 patients that you've seen in your shift, might have been handed off to you from, the shift before.
Right.
So not only is it keeping track of everything that's happening, with your direct involvement, but it's also what happened before and what's going to happen after, and ensuring, I assume, that all that communication happens kind of seamlessly as well. So that handoff process is pretty important as well.
Yeah, we do spend quite a bit of time, you're right, Chris, on trends and getting that information. And that's what nursing informatics folks do is
Right.
they take data and they present it in an easy to understand fashion. So whether it's vital signs trends or notifications to advanced providers or medication compliance, whatever it is, give me an infographic.
Right.
Display that information for me very quickly. And that's where those EMRs are, they're evolving to say, okay, we got all this data. How do we make it make sense? It's presentation, but it's also digesting large clinical summaries that I really don't need to read all of this, because a lot of it is just, it's cookie cutter recipe. But those things that are outside the norm, pull that out. Use AI or machine learning to pull those things out so I could quickly look at a snapshot of this patient before I move on to the next one. And I know things to look for. I know what their tendencies are. And, it helps me spot red flags very quickly. So got to use the tools to make it happen.
Yeah, it's interesting. And obviously you brought up AI, and let's go there next. As I always joke on this program, you can't have a digital health podcast without mentioning AI. It's in our contract. So let's talk about AI, and obviously so much of what we talk about in healthcare, and frankly, what a lot of what we've talked about on the show around AI has been relatively, I'll call it physician-centric. And while there may be some crossover in terms of what physicians need and what nurses need and so on, I'm curious about what sort of nuances or perspectives should we be looking at AI through the lens of a nurse, and where do you see some of those opportunities? And I think a couple of those examples that you gave are really wonderful in terms of optimizing the workflow, in terms of data visualization. But I'm curious about your perspective on that. Where do you see maybe some differences between the way that we should be thinking about nurses, clinicians versus physicians, and the way that AI could support those groups?
Yeah, and I understand completely why advanced providers and physicians that's where we started, because one, it's an economy of scale. They only
Right.
spend 15 minutes in a 24-hour. It's easy to capture that encounter.
Right.
It's quite the opposite for a nurse at the bedside who's going in and out of that room multiple times, whether I'm taking them to the bathroom, I'm chopping up their lunch, I'm administering their meds, I'm placing an IV, whatever it might be. There are so many touch points where a nurse is interacting with patients compared to our advanced providers.
That's right.
It's just different. And it was an easier path to get the win first,
Sure.
So now you're starting, and I've got some friends who are in PhD programs, and I've been doing some testing with them and that type of thing around ambient listening from a nursing perspective. And from nursing school, we've always sort of dictated what we're doing just because it's patient teaching. So we've been staging ourselves for this. So we're already reflexively saying, okay, now I'm going to insert an IV into you so that we can get this potassium. And then after that's done, we're going to run some fluids and you'll be able to get your antibiotics. So I'm already saying what I'm doing. So that stages it well to be captured. But there's so much information, so many data points. What's the most important thing? We read vital signs off to patients all the time. Your temperature looks great. It's 98.4. Your blood pressure is better than it was this morning. You say these things to the patient as part of your education. So we've already been staging ourselves for that ambient capture. And now we've got folks like IBM interested in that and working with some of our PhD nursing folks and in some of our nursing research centers to say, we can do this and we can transcribe it. And then we can actually, if you want, we can put this in a note, or we can take discrete data, put it in certain fields. So that's one thing for AI. And American Nursing Informatics Association, we have well-attended pre-conferences about AI every year at our conferences, and that's just only going to continue to increase. And that's a great fit for nursing informaticians, as well as building those prompts and those queries and that data presentation once you get those query returns. So it really fits well with nursing informatics. And we have our conference in Boston next March, and we've already got some good AI stuff already lined up, and our members really gravitate towards that because it makes sense to us. But
really interesting.
But more than just that listening, Chris, what really drives me and what I want to focus on, and I'm anybody that listens at work, they're probably tired of me talking about it, is those proximity badges. Because I wear a badge so they know where I am anywhere in that hospital, and they know how often I went back and forth in the room. And if a patient falls, one of the first things they look at is, when's the last time this nurse went in the room? Compared to the fall, when the alarm went off, whatever the case may be. And it's simple things like alert fatigue, where if I am holding on to a patient, I'm there at the bedside, and I forgot to turn off the bed alarm, and I was pulling them up in bed, and I triggered the bed alarm, there's no need to start this chain of hoopla.
Right.
Why not pause that while I'm in the room, and when I walk out of the room, it knows I just walked out of the room, turn the bed alarm back on. If I walk in, turn it off, so that I can interact with my patient without triggering all this hoopla, which then triggers everybody's radio. And then what happens after that happens 40 times in a 12-hour shift, our nurses just start turning it off. We're not going to respond to those things because we know there's more than likely a nurse in that room who probably just triggered that. So those are the things that I want to work on, is that proximity censoring, to say, machine learning or AI, whatever the case may be, for those patterns, so that we can start to, one, address the real thing of alert fatigue around whether it's an IV, whether it's a fall, whatever the case may be, so that now that we're doing all this real-time tracking, let's incorporate that into our workflow to make it, one, easier for me to do my 12-hour shift and come back tomorrow not crazy about it.
Right.
Knowing that all these alarms are just going to be beeping, help it make sense and get rid of the noise. Those are the things that I want to chase with the technology, with AI and machine learning.
So interesting. I mean, that is, really practical examples of how kind of the intersection of technology and optimizing the human experience, to be, human behavior,
right,
can really be impactful.
Yeah.
And I know one of the other things you've talked about in that space of kind of where the human element of this comes into play is around music. And this is fascinating to me, that one of the more kind of creative things, I guess, that you've looked at is potentially using music as part of the informatics toolbox. So can you talk to us a little bit about this and explain how digital tools like patient-selected, meditative music might become part of a frontline experience in the not too distant future?
Yeah, there are some great leaders in that space. One of them is Coral Health, and one of the roles I had when I wasn't at the bedside was I did some business development with them, with a vendor who dealt with a call system that could also prompt for education. And that's another great example for AI, is give me the education based on what's going on, data points in the record. Says, oh,
Right.
You're getting Lasix and your creatinine's going up. Well, let's give you a quick video on what acute kidney injury looks like and what is creatinine and all those things that could happen passively without a nurse staging that up. And it just shows
Right.
on this education system, because there's a television in every room, or there's an iPad at the bedside, whatever the technology format looks like, the form factor. That's where you start including that ambient listening to say, okay, maybe now I can, there's anxiety, there's touch, there's trigger points or whatever around anxiety, bringing some calming music into that. You've got these whiteboards now that digitally bring in what the schedule is. I know you're going for an endoscopy this afternoon, you're MPO, you're probably going to be a little hangry. Let's calm you down with a little music. Based on your age, here's some suggestions on things that, and you can pick as the patient, give them control of it. And so that's where folks like this Coral Health group, they look at spiritual music, they look at motivational, they look at things that can distract patients. And, when I deal with Alzheimer's patients or patients with altered mental status, I whip out my iPhone many times if we're doing something, and I'll just bring in some relaxing music. It's instrumental. It just lowers everybody's blood pressure. If it's a hospice patient, we'll bring in a radio and just have music quietly playing. It brings the temperature down. It lowers people's blood pressure. This is all well documented, but I think it's underutilized. And it's a way for nurses to relax and be able to focus. But you can see a patient's face change if you can find a song that they remember from their childhood, or they associate with a good friend or parent or whatever. When you bring that song in, all the senses turn on, and they just change. Everything changes. And if you can find that right match for that patient, it's an amazing transformation of how things can that anxiety can just drop through the floor. And we've got music channels at our facility now, and I'm often going in and just turning on a channel. I'll look for swing music from the 20s for my older patients and stuff like that. Something they can recognize. It just lowers their anxiety, because it's a whirlwind of activity and anxiety, and they're afraid. So if you can start to reassure them and comfort them with something they recognize that brings them peace, why would you not use that? And it's going to,
Absolutely.
I've seen it so many times, whether it's I pull out my iPhone and play a Stevie Wonder song for somebody and we're all dancing, that helps that relationship bond between me and my patient. They're like, he really cares about me at a human level. He's not just in here passing meds and he's gone. He wants me to feel at ease. He wants me to feel better. It's going to start me on my healing journey, whatever that case may be. So I think that's where vendors can say, how do I get that at the bedside? How do I queue that up? How do I make smart selections about what's needed and when, what's appropriate for the age group? All of those things, you can just build those right into platforms that exist now. Granted, yeah, I can call for ice or I can get my pain addressed or whatever the case may be, but why not give the patient or family member the ability to bring in some relaxing music that can help them get through this experience of being in the hospital?
It's so interesting. And what really strikes me is that where we sit on the roadmap, if you will, of the technology that's here and obviously rapidly evolving for the future, the spectrum in terms of the outcomes and the benefits that we can affect here. I mean, you've described everything from making a clinician's workflow more intuitive and more effective through RFID badge reading.
Mm-hmm.
You've talked about reducing the documentation burden and making that easier through ambient listening. You've talked about being able to bring tools like this in from a relaxation or meditative perspective. I mean, it sounds like the opportunity that we have here at our doorstep, we've never, it seems like, been able to treat the patient more like a person than we can like right now.
Absolutely.
If we bring this world together. Is that fair?
Absolutely. And Chris, we're at the hospital I work at, we're in the process of starting a 2 to 3 year doubling of our bed size. We're going to build a brand new tower.
Wow.
And I am right there at the forefront saying, okay, this is what we need to have in the room. We've got to have these smart whiteboards. So I don't have to worry about, because I'm already signing in, associating myself to this patient. So it knows I'm the nurse. It knows this is the tech. It knows the doctor. It knows their diet. It knows when their next medication's due. It knows all of those things. Why not just put it on this board that they're just sitting in the room looking at? And then how do we incorporate music into that? So you've got this board, let it play some music, have these speakers that we can clean, when we turn the room over and that kind of thing. So always looking for those, and those proximity badges with our beds. Turn off that bed alarm when I walk in the room, because I'm there. There's no need to alert me. I'm holding on to the patient. Looking for ways that we can embed our technology so that nurses don't even have to think about it. It happens passively as I walk in. So then the things that I really need to document, I have the time to go actively do those things, and that includes mobile form factor. If I have to just go give someone a pain reliever, I don't want to go look for a wow or anything. I just want to go in with a handheld, scan their wristband, scan the med, document that I gave it, instead of having to go through all of this other hoopla and dig through to where I need to be. So you're right. We do have the technology. It's just a matter of putting it together and look for those opportunities. Like I just mentioned, you're building a new hospital. Nurses need to be there at the forefront saying, here's what you need to do. And this is how you need to build this smart room, and then anecdotally, this is a great place for research, is do these things and let's compare fall rates. Let's compare infection rates. Let's compare people that are coming back in the hospital, all of those things. And, you can certainly quantify clinician fatigue, all of those things. Those things are going to come down. That's just the way it is. If technology is done right and implemented right, it just translates easily into clinician satisfaction.
Absolutely. I think it is such an interesting time and an exciting time to be in the space that you live every day, that we're fortunate enough to be a little bit on the peripheral of, but nonetheless, really, really exciting times. I know we're almost at time here. I want to open it up. Anything that you're working on that you're excited about, that you want to share with the community, certainly please tell folks where to learn a little bit more about the American Nursing Informatics Association, but anything that you want to close with here, Mark, today.
Yeah, so I'll just tag onto that, Chris. For American Nursing Informatics Association, it's about 3,300 members. You don't have to be a nurse, but most of our members are nurses. We've been around since I think 2012 is when we brought two East Coast, West Coast organizations together to form where we are today. I've been on that board for 8 years, so next year I'll be the immediate past president. It's been an honor to be able to serve our nurses in that. One of the things that we're working on it's been a multi-year project, and this will be nerd speak for some nurses, is making care plans actually mean something. For so many years, we would just throw a general care plan at a patient, but it wasn't specific to them at all. So to go back to that AI machine learning, why don't we use the software, the EMR, to look at data points to create triggers based on a lab value, based on a flow sheet that I documented that they are not normal with their gait, or they have something wrong with their GI system or their GU system, so that it can cue you to say, hey, you probably need to add this care plan. Because for so long, care plans have just been something we did in nursing school and something we had to create. Why not make them meaningful and specific? And then that's the key word. You talk about specificity with medications and those types of things. So from a nursing standpoint, that's a holy grail, is having a care plan that's specific to that patient based on documentation that's already in the system. And that's where machine learning and AI can really help. And so we've been on a couple-year journey of optimizing our care plans, standardizing them with the terminology, but more importantly, building triggers so that nurses can say, and they don't have to accept these triggers. It's just a recommendation to say, maybe you should add this care plan about, altered urinary elimination or something like that, based on something that's been documented. So that helps with that documentation burden. Is I'm letting the system work for me and giving me these recommendations. And I think we're going to see more and more of that as these EMRs start to utilize these AI tools. So we're going to have more recommendations be given to nurses, instead of just saying, okay, you got to figure this out based on the last 100 patients that you've dealt with that look like this. Right. Here's something unique about this patient you may not have noted, because there's so much information. They've been in the hospital 20 times in the last 3 years, and you didn't get a chance to go through all that. But we do see this data point. So we're going to suggest something for you. So I think that's a tool that we've got to, we're going to continue to work on that. There's a lot of optimization, making sure the triggers are appropriate and it doesn't contribute to the noise. One more thing they've got to deal with and address that recommendation. So that's something that we're at Prisma, we're working to make it a better experience for our nurses, which will then translate to better outcomes for our patients, because we're starting to frame our goals of care and our plans of care around things that are very specific to the patient that's in front of us, not just some generic patient out of a textbook somewhere.
Such great work. I hope you'll come back on and update us as you continue to move through that project.
Absolutely. This has been a great, as you can see, a lot going on and a lot to talk about, and I always appreciate an opportunity to do so.
Well, this was great, Mark. Thank you so much for coming on, and more so, thank you for your service. Thank you for your family's service. Thank you for everything that you do for patients on a daily basis, and thank you for everything that you're doing to try to take healthcare forward. It was such a pleasure to have you on.
Absolutely. Thank you so much, Chris.
And thank you also to our listeners. If you enjoyed the conversation, please like, share, and subscribe to help us keep growing the show. And if you'd like to learn a little bit more about Taylor Healthcare and the digital healthcare experience, you can go to taylor.com/digital-healthcare. That's our show for today. And until next time, this is Chris Civit-Therese wishing you health and good cheer. Take care.
To learn more about Taylor Healthcare, please visit taylor.com/digital-healthcare. This podcast is for educational purposes only and is provided with the understanding that it does not constitute medical, legal, or financial advice or services. The Digital Healthcare Experience is produced by Naomi Schwimmer. Podcast music by Nicholas Bach.
The more engaged the patient, the better the outcome. But how do you help patients get engaged? Introducing iMed Health from Taylor Healthcare. Digital tools that increase patient engagement at every touchpoint. Go to imedhealth.com to learn more. Find the link in the show notes.